and welcome to the June Primary Care Commission Committee. This is the last committee of the CCG PCCC before we transition to the ICS ICB on the 1st of July. So welcome everybody. Thank you for joining us. So we've got, I haven't taken any chairs actions between the previous meeting and this current meeting. Just a reminder, the meeting is recorded and will be put on the YouTube channel. Can I ask for any declarations of interest, and also for people to keep their declarations up to date, including close family members? Karen.
Thank you very much, Doris. I've got two conflicts of interest I need to declare. My son-in-law works at the NNN, is a medical registrar. My daughter, not my daughter-in-law, my daughter is an OT at NCH&C. Thank you, Doris.
Thanks, Karen. And Tracy?
Yes, I think in respect of item 9, locally commissioned services, I do work within primary care across Norfolk and Waveney, but that has been acknowledged and I won't comment or take part in those discussions.
Thank you very much. I'll move on to the minutes of the last meeting. I will take any questions in terms of accuracy or matters arising that are not on the agenda. I had a very minor one on item 5, the forward plan. I think on the third line, I think there's just something's missing because it says forward planner e-update. So it just needs correcting for the final version of the minutes. Are there any other comments from anybody? No. Oh, I forgot to do apologies. We have apologies from Bill Borrett and Mark Burgess. I think maybe also, Kathy's back. Sorry, I thought Kathy was still halfway around the world, but she's back. So she might be joining us at some point because we haven't had an apology from her.
Kathy's here, Doris.
Oh, she's right. Sorry, I'm just running a bit slow on my screen today. Thanks, Hein. And the action log, there is only one item on it, which was in relation to Brundall, which presumably will come to a committee meeting in due course if anything transpires on that one. Does that need to stay on the action log, Sadie?
The action in relation to the interface item, do you mean? For part 1?
Oh, sorry, I'm looking at part 2. I've got ahead of myself. I do apologise.
I think we have listed the interface report for next month on the draft agenda, so I think that can probably be closed today.
Right, that's fine. So once we get to the forward plan, we can, because that was sent out as an extra yesterday.
Yeah.
Thank you. So I will move on to the forward plan.
Sorry, Doris.
Yeah.
Sorry, I was a bit slow on the hand there. Just before we do, there's one action that I don't think we've captured on the action log, which I wouldn't want to lose sight of, which was, I had a discussion last time about severe mental illness health checks, and there were some questions around the paper last time, in particular the financial implications that needed to be resolved. So I think it'd be good to just note that on the action log, that there was an outstanding action there to be picked up at a future meeting.
That's fine. I thought there was going to be a new paper coming back with the full proposal, but either if we have it on the action plan, then it's picked up in due course. That's good. Thanks, John. So on the forward planner, I think the forward planner is really the draft that was sent out yesterday, because the forward planner on the pack is really runs up to this meeting, and then it's a transition onto the ICB. Are there any? Do you want to just maybe just give everybody just a brief overview of that, Sadie, in case people haven't picked it up on emails and things?
Yes, of course, Doris. So hopefully people will see it in their inbox somewhere. What we've tried to do is have a little look at kind of how we've been working over the last year or so, as well as thinking towards the future. As you can see from the proposed, we have suggested that we spread out the risk register and bring that every other month. It would be good to understand people's thoughts on that, and I think really that's in line. Our governing body currently, and our ICB, I'm assuming will do the same, meets in public every other month. And while of course these are very live pieces of work for the officers, they don't just look at it once a month when it comes to updating the report. It was felt that we would probably be able to show more progress if we reported every other month, as opposed to because some of these things are really complex. So hence the proposal there. The rest of it is fairly standard. We've kept quarterly reports in for the things that we used to have quarterly. We've removed locally commissioned services, as that project is pretty much BAU. We're just finalising the warfarin LCS, and we're bringing back a final paper, which I don't think is on there actually, next month, around the public engagement piece. There's still a date to be confirmed in there around the report on delegation, just in terms of timelines with NHSEI. But very happy to hear any thoughts either now, or given that it was only circulated yesterday evening, by email outside of the meeting, if people would prefer.
Thanks, Sadie. That's very helpful. And I think, you know, the new committee, when it's up and running, will probably have thoughts as well. But that's kind of starters for 10, really, isn't it?
Yeah.
I kind of noticed that the you know, pre sort of pandemic levels, we used to have fairly regular feedback back from the localities, and that seems to have disappeared, and so that's my question to the future committee as to whether that is something they want resurrecting, and it may be that actually you don't, but that's my question.
My initial thought on that was that with the new governance in the ICB, there will be a people and communities committee, or place and committee. Sorry, I've forgotten the exact name of it. But there will be a committee around development of primary and community provision, and with the Fuller report and the new primary and community development board that will be established as part of the ICB, my thoughts were that it was likely that PCN development would be reported there, and that the primary care committee would become more focused on the contractual side of delegated commissioning. But of course, we can see how all of that goes.
I think it'd be good if it goes somewhere. It doesn't necessarily, and I've forgotten about the new arrangement as well. So that's fine for me, and it's for the future to work on. Tracy.
Yeah, I mean, I support what Doris said. I think it would be great to know that place. I mean, place is going to be so much bigger, probably, isn't it? So I understand why it's kind of sitting somewhere else. But there's that element of kind of PCNs around place and workforce that I think probably should sit with this committee, and how that comes to it, I don't know. Just reflecting on the risk, I think it's right to have the risk alternate month, so you're not, you see progress and various things, but just wondering if there's something that comes up as high priority that you have the means to then bring it to a committee on that particular month if there's something that comes up in between that times. And just something that occurs to me in respect of the QOF kind of actuals. I don't know that I've always found it helpful when we brought around the COVID vaccinations to this committee, when it has been particularly focused on primary care. And I think that role of immunisation and vaccinations for primary care is a increasing role. So whether or not that's something just need to be considered as well, because it really does relate to all the health inequalities work as well. So I think it'd be good to see that had a place where there was some oversight over immunisations and vaccinations. Thanks,
Tracy. John?
Thank you. A couple of brief comments. One is learning disability and autism health checks. I know we've had a lot of good discussions on that on a monthly basis. I see it's moved to bi-monthly going forward. So I just wonder if that should stay monthly, just to keep that focus on it, because it's a key area of work, isn't it? So that's a question, I suppose. The other question I've got is referencing the fact this is about delegated commissioning, and that on the horizon there's other aspects of delegated primary care that may be coming our way. I don't know if that will actually be in the remit of this committee going forwards, but if so, there's probably something about some periodic updates on the direction of travel for that.
Thanks, John. Kathy.
Thanks. Certainly, I was going to make the point that John did about learning disability health checks, because particularly when the proposal is going forward, we're going to target the hard to reach people first. So it seemed to me that we needed to keep a closer eye on it in the early days. The second thing is that at the Quality and Performance Committee, we have a dashboard of the risk register, and for simple folk like me, it's an easy way to see really quickly whether there's a movement in risk. And I wondered if you're looking at risk bi-monthly, expecting more movement, something like that might be helpful going forward.
Yeah, I think we did have a dashboard at one point, and it kind of got dropped off with other commitments, but I think it'd be good to resurrect it at some point. Sadie.
Thank you. All really helpful comments. Thank you. I think in terms of Tracy's comments first around IMS and VAX and what have you, the intention remains that we will have, we've been calling it a dashboard, haven't we? But we need a performance report, I think, around all areas such as IMS and VAX and the health checks and what have you. And I know that the BI team are working really hard to try and resolve some of the data sharing issues that we have at the moment. So that is still there in the background, but we haven't gotten a way of being able to do that very easily just yet. In terms of the other primary care contractors coming on stream, you'll notice in the planner that we've got a terms of reference review in December, and that's been proposed by Karen Barker, who's leading all the governance sides of things for the ICB, and that is what that review is for, to enable us at that point to be able to have a look and see kind of how we manage the committee versus any kind of delivery boards and what have you, to enable us to free up the space for other primary care contractors. On the point around learning disabilities, I think whilst we've left the risk score reasonably at the same level, it's still showing red. In actual fact, the structure that we've got around that programme of work now is really quite robust, and I think we were pleased with the end result. Of course, not pleased enough. We're never pleased enough with the coverage, and I think Shepherd is obviously going to present the report today, and I would ask him just to cover that, because I think our view was that, you know, yes, we can bring a monthly data report showing progress, but we think perhaps, you know, in order for us to focus more on the programme of work and less on perhaps a small monthly report would perhaps enable us to do more around learning disability health checks, given that the infrastructure around the programme is there, and actually switch our focus to the severe mental illness work, which again we're trying to implement the same sort of structure that we have around learning disability health checks. And the final point I think was on the summary, the risk register summary, and I know that we've been asked to do that more than once, so thank you, Kathy, for the reminder. Shepherd has kindly dedicated some resource to me for the purposes of continuing to improve the risk register. So we will see if we can implement that from the first committee of the ICB next month.
Thank you, Sadie. Kathy, do you want to come back in?
Yeah, it's a small point, and it may not be relevant in the new arrangement, but what I was thinking of, Sadie, when you were talking about performance, I accept your point about the learning disability checks and needing to free up some time from reporting to actually doing, and that's fine. At the Quality Committee a couple of months ago, Ed Garrett offered us the challenge of seeing whether we could express all performance indicators in terms of patient harm or quality implications. And I just, it just struck me while you were talking that challenge has resonance here as well, doesn't it? Because we've had the conversation about, you know, you've worked really hard and achieved really good standards in terms of learning disability health checks, and yet what happens to those people who don't have them, and also about the quality of the checks. So I just want to draw that to the committee's attention as a line of thinking that the Quality and Performance Committee are pursuing, and it may be something that resonates here too.
Thanks, Kathy. I think that's a very kind of helpful challenge and reminder of why we're all here at the end of the day. So maybe that's some thoughts can be put for that for the future work of the committee. That'd be good. If there's no other comments, questions, I will move on. But obviously, if anybody has any thoughts, please let Sadie know so it can be refined for the work programme for post July. I'll move on to the risk register, which we started to touch on. Do you want to highlight anything before I open up to discussion?
If I'm sorry, Shepherd, if I may, Doris, we've had I think we were asked to do a bit of a comprehensive review of the risk register last time, so we've actually gone through, we've had quite a detailed review of it with each of the risk owners and risk leads. So there's a few things on here I'd like to draw committee's attention to, if I may, and it's actually there's been changes in most of the risks this time. So PC1, which is the workforce risk, first of all, I must just point out there's a slight error on the arrow at the very end. It shouldn't be an upwards arrow, and we will resolve that for next time. But as you can see from the recommendations in the action log, we are recommending that we create 2 risks around workforce, and I think that's because as we've been sort of reviewing the work plan for this year, the risks around GPs and nurses are actually different to the risks around the rest of the workforce and the additional roles reimbursement scheme. And I think, you know, particularly around the additional roles, Norfolk and Waveney GP practices are doing a fantastic job of, on the whole. There are still some areas where there's a real struggle. On the whole, are doing incredibly well around building the workforce in those areas, but we know that some of the challenges around GPs and nursing are really influenced nationally and are much harder for us to progress with. So we would like to be able to separate them out so that we can score them appropriately and add the appropriate timelines to those. PC2 the estate's strategic plan, Paul Hyam has recommended that, excuse the helicopter going over, that we close this risk because we have been able to significantly reduce the score this month and meet the tolerated level of risk, and that's also in line with the target delivery date, and you can see in the action log his rationale for that. I won't go into PC6 because Shepherd will cover that during his agenda item, but we do expect to be able to reduce the risk score on that next month. The next one is PC9, which is hypnotics and anxiolytics. That remains a high risk, but you can see that the risk itself has been comprehensively updated. There's a proposed change to the target date on that one as well, and as you can see that there is really positive progress on this this indicator, but we don't look as if we're any different because of everybody's working on this nationally. But the medicines team, as well as working with practices through the prescribing quality scheme and focusing some work on outline practices, the team is also starting to work with the Mental Health Provider Trust around prescribing on this, so trying to target the issue from both ends of the problem. The next one is PC11, which is the interface risk, and we will have a more detailed update coming to the new committee next month. There's a proposed change to the target date there, which has been largely due to unplanned staff absence and capacity. We have managed to focus a new member of staff onto that programme now, so we're getting a bit of progress happening again. We have had the first task and finish group, which was very positive, although as is always the case, you discover more and more complexities as you start to dig into some of these issues, which is why they've been a problem for such a long time. Sorry for the monologue here, by the way, do jump in at any point. PC14 is the next risk I'd like to highlight, which is also on the governing body assurance framework and will transfer across to the ICB assurance framework. And this is the impact on general practice from the COVID-19 pandemic. As you can see, we have slightly reduced the risk score this month, which has now met the target score. We are suggesting that we just continue to keep an eye on this for at least another month, just because we never quite, I know we have the living with COVID guidance, and we've just had new infection prevention and control guidance for general practice, but we are seeing some case rises in other parts of the country, so we think it's probably sensible that we just keep an eye on this for a little bit longer before we propose it to be removed from our risk register, albeit that it will still be a focus for us as part of normal business as usual work. Sorry, nearly there. PC15, which is the 4B primary care hubs. There's quite a significant reduction in score on the risk rating this month. And from the update, you can see all the work around the business cases that are going on within the estates team, who I think feel much more confident than they did before about the progress of those schemes. That will continue to be monitored in the new committee due to the target date being 2024. And finally, just to highlight the new risk to you of PC16, which I think you agreed at the committee meeting last month. And this is the severe mental illness, physical health checks risk, and has captured all of the information there that you received last month, and provides an update for June. So I'll stop talking now.
Thanks, Sadie, for the comprehensive run through of the risk register. Are there any questions from anybody for Sadie? Hein?
Thanks, Sadie, for the update. I would leave the risk for PC15 as is, so it's encouraging to read the progress made, but as you know, this risk has had many twists and turns along the way, and I'd rather wait for the approval from NHSEI to come through in September. So it's a bit caution given everything we've gone through. That's my counter proposal, if I can put it like that. Thanks.
Might have to look to John for that one, because I don't think Paul's in the room today.
John, did you want to come in?
I think Hein's suggestion is very sensible, actually, because, yeah, as you say, we might feel like we're on track, but it wouldn't be unusual, would it, for things to change at the last minute? So, yeah, I agree. Let's keep that at red.
Yeah, I would agree with that. I think it's given the many twists and turns, let's be safe than sorry on that one, I think. Tracy?
Yeah, just to agree about the general practice workforce, I do agree there are slight differences, and I think it is right to separate the R's roles to the kind of, particularly the clinical roles, the GPs and the nurses. But I also think there's the wider primary care workforce as well. It is the support staff who for whatever reasons, move about quite frequently. They do find that their jobs very stressful, and certainly our practice managers as well. So I think it's inclusive of the whole of the primary care workforce. Obviously clinical is vital for patient services, but so are all the other supporting services as well.
Thank you. I had a question. I know PC2 we're planning to close it, I think, on this estates strategy. But there was a comment within the paper talking about the PCN estates strategy is still yet to be developed. So I'm kind of scratching my head a wee bit. If we haven't got a strategy, how come the risk is lower? Or maybe I'm thinking about something completely different. John?
I'll try and answer that, but Sadie might be better placed. That I think it probably reflects the fact there's been a lot of work done over the last couple of years to have a strategic view of primary care estates and to understand where our areas of need are in terms of population growth, existing building condition, etc. So I think we've got a good view now of where the areas of priority are. Maybe the gap is that PCNs as entities, if you like, haven't got their own views necessarily of what they want as the future for their particular patch. But if our focus here is about primary care in the round across North Cumbrae and being clear that we have got a strategic approach to the development of premises, I would agree with what's on here. I think Sadie might be better informed than me.
Save me, Sadie.
Just to add to what John has said, the same query that you raised, Doris, was raised by the LMC, by their estates lead with Paul. What Paul explained was that because of what's been put in place around, as John has explained, to enable the estate strategies, it's reduced the risk score. It doesn't mean to say that we've got the piece of work, but that we're not worried about having it, I think, is the where we're at. So it was raised as a risk because we didn't think we'd be able to get there. Now the team is very confident that all of this work is in train and there's the right infrastructure around it. So it's not that the work is finished, it's just that the risk around it is reduced and has met what we set out as our target when the risk was originally raised. So the work will continue within the estates team, but it isn't a risk that they believe needs to be escalated anymore.
Okay, no, that's fine, because we have an overview of is the difference between you know, the general review and actually down to the nitty-gritty minutiae. No, I'm happy with that. Thanks. Are there any other questions, comments? John?
Just a brief one, Doris, on PC14, which was related to the impact of the COVID pandemic that we're planning to close. It's just something in the latest update there, which is talking about the increase in unpleasant and abusive behaviours from some patients, which is impacting on retention and I guess possibly recruitment within practice as well. This has been a theme for several months, hasn't it? So I suppose just a comment that happy to close the risk, but that we don't lose sight of the issue there. I'm sure it will come back periodically anyway if it's impacting on recruitment and retention, but it just felt an important issue not to lose sight of.
Sadie?
Yeah, I think this links back into PC1 as well, because the PC14 risk is around the impact of the COVID-19 pandemic, and it does overlap quite a lot with the resilience risk and the workforce risk. We are proposing to keep an eye on this and not close it just yet. In response to John's point, I think it is something that we are worried about. The comms and engagement team are supporting us with a campaign around primary care. We've also raised it with the Health Overview and Scrutiny Committee and had the support of all the councillors sitting on that so that they can help make sure that behaviour is appropriate when people find that they can't get the access that they might first want. NHS England has also recently updated their policy and guidance manual for general practice, and they've included a whole new section on managing inappropriate behaviour, which includes a couple of template documents as well. One is a standard letter to go to patients who are rude, abusive, what have you, and the other is a template patient agreement to set out what behaviours are expected and what they will get from the practice in return. And all of that is designed to try and moderate poor behaviour and give people a chance where it's appropriate to do so to remain with the practice before the relationship breaks down and they end up being removed from the registered list. So there's quite a lot of work going on about that, but it is definitely an ongoing problem for many of our practices.
Yeah, thanks, Sadie. I think it's a sort of general society problem as well that I think we just need to keep focused and keep working and keep encouraging and keep challenging, I think, as well. That's great. Thank you. Are there any other questions before we move to the next item? No, thank you. So on to the learning disability health check. Shepherd, are you taking this?
Yes, I will. Thank you. So this is a summary report, which just helps to aid some discussions with the committee. You've got a flavour of where we landed at year end, which is just over 70% short of the national target at 75. And within that, just to refresh the committees on where we did so well, I think we saw some significant improvements from West Norfolk and Norwich area, from 50% in Norwich last year to almost 70% this year. And again, from West Norfolk, we saw some improvement within the 60% area to 70%. So we've seen a small drop from the other localities, but that is quite consistent with the patterns that we've seen nationally and in the region. So it's been certainly a challenging year for the country and also for us as a region. I think it's fair to say we are the most probably improved system if we look at data across our system and also across the region and the country in some ways. So moving on to our priorities for this quarter and the next quarter, which is quarter two. it's fair to say we reported last month, and committee members challenged us on the 30% of the population on the register that we have not reached out. And I think the challenge is, what is it that you're doing to reach out to those families and individuals then? So I will take you through some of the game changes that we think will help us to reach out to those people that we have not been able to do. I'm really pleased to reiterate that we have engaged with Protect Now, and they are doing some work within Greater Yarmouth and Waveney in terms of supporting those practices that we have identified as needing that support. And that piece of work, we're looking to expand that across the system once we have done a review, but so far the start is strong. And also just to mention again that we've got an excellent resource within our system, and I think we need to cherish that. The peripatetic team, they've done a great piece of work to support the Norwich area in particular, and hence the evidence in numbers and also in the quality that Norwich area has reached. And I'm really pleased that we have now diverted the attention from to South Norfolk so that we can see similar improvements in that area. We are maintaining the resources that the additional clinical resources that we have put in West Norfolk, really to strengthen our grip on the improvements that we have started in that area. So really positive work going up there. Good cooperation and improvement. I think the relationship is strengthening in that locality. We are also, the additional resources have been put in South Norfolk, and clinics are starting, and that resource is led by psychiatrists and nurses. So we're really interested in those complex cases, individuals on antipsychotics, hard to reach area. So I'm really positive to be able to report next time how we are doing that. Then we've got the LD Champion channels that has been opened to all our practices and PCN colleagues, and really great work going on in terms of learning and lessons in that area. And I think there's also one excellent piece of work that probably we did not include in that, the work that Open Doors are doing to help us understand the feedback and engagement with people who have had annual health checks. And I'm really looking forward to the publication of their report that they've done across all our localities around that. So I'm looking forward to come back on that one. So we're really open-minded to look at everything that we should do as a system to be able to improve the care and treatment and the experience of people with a learning disability. I would welcome any kind of reactions, comments, question, challenge, suggestion on how we can strengthen what we are doing.
Thanks, Shepherd. That's very helpful. Just before I open up, just a question for me was around, I suppose, data, because that's linked to the risk register about, encouraging patients who haven't had checks before, and part of the NHS E&I guidance that's come forward. Is the data going forward going to be able to split out and identify new take-up so that it can be monitored, or is it just going to be lost in the realm of, it's just we're trying to make sure that the people who didn't get the health check last year are kind of prioritized, but I'm not sure whether the data is going to be able to help us understand that that's being achieved.
Absolutely. I think the beauty about the way we are organized, or the funding streams, or the way this is funded, allows the practices to be able to identify who has not had an annual health checks. So it's easy for us to identify. We already know how many people in each practice that have not received it, and we have communicated with the practice to say, you've done this number and this is how much you have not done. So they need to be able to get to that number and align with the individual or the people that in their register. Did I understand your question right?
Yeah, I suppose it's about reporting upwards.
Oh.
It's in terms of reporting, is there going to be like a separate line for practices to say, we saw 10 patients in the month, and actually 2 of them have never had a health check previously, and I think it's important everybody gets one, but it's doubly important for those who actually haven't had a check for many years, so that they're captured and assessed, and any preventative measures can be put in to help them have a healthy life.
Yeah, it's going to be tricky, but we are interested in actually identifying those 2,000 for reporting upwards purposes. We know that in South Norfolk, we're expecting 400 to 450 people that have not had annual health checks done. So that we can track that way. But as a system-wide, we don't have, that has not been created per se. What we will get in areas is going to be the NHS England monthly reporting that shows us how many people have been reviewed, and those will be the people that have not had annual health checks.
Okay, so it can be separated out in the future for assurance to the committee that things are moving in the right direction, and it may be a piece of work in progress that you need to think about and actually refine the reporting, so that's because I'm just kind of not quite sure how the committee is going to get assurance going forward that we are reaching a new cohort rather than the same people, and we need to reach the same people, but we also need to reach new people.
Yeah.
Sorry, I'm taking too much time. Karen.
Thank you, Doris, and thank you very much, Shepherd. It was a really good report, and some solid progress has been made. I think one of my comments, and they're more comments than anything else, is I'm really, really pleased to hear about the engagement that's happening, because I think that's the key to unlocking why people aren't attending, and how possibly with Protect Now we could identify groups that just don't attend, and for whatever reason, and thinking about some of the work we've done moving forward, how we have to take the assessments to people rather than people coming into clinics. Maybe we need to be thinking about more opportunistic ways of meeting that obligation. I'm just thinking in terms of the vaccination programme, but I'm also thinking about what are people telling us that are using these services, because when we did some work many years ago, and we invited a number of people to a governing body, one of the strong feedbacks that we gained from people with LD and autism was about having time and space to speak, and also an appropriate environment. And I think that's really important, because we need to ask people what would make it easier for you to attend, or your family to support you. Sorry, I'm probably stating the absolute barn door obvious when you're doing that, but I think it's a really relevant point. Thank you.
Thanks, Karen. Tracy?
I mean, my comment was similar to Karen. I mean, I'm very pleased that the missing kind of 30%, we're having a real focus on that, which is really important. But I do think certainly we do need a cultural change here, don't we? So certainly if the data, the insights we're gathering from Together, we really do need to utilise that insight to change practices culturally in the way we're kind of supporting, working with communities, so that those voices of the community and that insight is going to be vital to changing practices going forwards. And I do think there will, I'm sure there'll be some individuals will really struggle to go to any kind of clinical setting. So we've got to be prepared, I think, to do a bespoke offer that meets the needs of individuals that just, you know, the setting we would like them to have the health check isn't the right setting. We've got to have a bespoke offer, a team that can be mobile and just offer that in whichever is the most appropriate setting and the most appropriate way to do it. So it's meeting the needs.
Thanks, Tracy. John?
Yeah, thank you. On a similar theme, really, and just agree with the fact it's really important to focus on those people that haven't had a health check. And I wonder, in terms of the reporting going forward, I wonder if we should report similar to what we do in other sectors, actually the longest wait, if you like, for someone to have a health check, or the longest time since someone's had a health check, if we can record that from systems, so we know if someone hasn't had one for 5 years or 2 months type thing, we can then just get a sense of what's the longest gap since someone's had one, and then we can focus on those longest waiting cohorts. Maybe it might be a way of getting into it with the reporting.
Some food for thought, Shepherd.
Thank you for that. Very helpful. I thought probably I should give you some early heads up from Open Doors, because I think colleagues have started making comments about engagement with communities and stuff. The early feedback we've received from people in the community is that they would like to be communicated with or invited via the phones. So that came quite strong in the feedback. Emails were zero. No one wanted us to be in touch with them via email. The second best option of contact was actually the letter, but I think it was less than 30% of people wanted that kind of communication. So I think we are going to intensify our efforts around talking to people more than writing to people. So.
Thanks, Shepherd. Sadie?
Thanks. I just wanted to add to some of the discussion, if I may. I think we know that we've got this 30% of people that we haven't yet reached from last year. And I think Shepherd and his team are trying to look really sort of creatively about what we can recommend to you or to the future committee for commissioning, building on the peripatetic team approach, to do just what Tracy has said, which is where we kind of have to go out to people who just don't want to come in or don't understand or have particular anxieties. And I think that is something that the team are currently working up. And certainly some of the successes that the peripatetic team have had with individual patients have been very much around really very intensive amount of time spent with somebody to explain to them and their family, and then to go to them to do the check. So it's a very resource intensive piece of work, and that means that it isn't always possible for practices to do that. So we do need to look at alternative delivery, and we will bring that back to you in due course. The comment, I think it was John that made about reporting the longest wait. The part of the problem that we have with that is that we can't access that data. That sits within individual clinical systems. So we're reliant on it being reported by 105 practices at the moment. But hopefully, as we continue to progress the data sharing work with the BI team and individual practices, we'll get better access to some of this data in future. At this stage, it's not something that we're going to be able to produce, but I think we should keep that on the list of things that we would like to be able to do when we have the technical ability to do it. Because I think it would be really enlightening to see that information and be able to use that to help us target our resources a bit more.
Yeah, I think that would be really helpful, because I suspect there'll be people who've never had it, never had a health check year after year after year. and they're the ones that we really need to go and support. Thank you. If there's no other questions, comments for Shepherd, I will move on. We're on to the 2 CQC reports. Is Carl taking this, or are you taking it, Shepherd?
I will take this too. Okay, so we've got 2 CQC reports received for reporting this month, and that is for Manor Farm and Wensum Valley. So I will start with Manor Farm. So this is a practice serving a population of approximately, I think, about 7,000 people. And the practice was recently inspected. It was previously rated as good, but this has changed to inadequate overall. They were rated good in caring and in also their responsiveness. They require improvement in terms of being an effective service, and they're inadequate in providing safe and also in the leadership domain. I can confirm that a lot of work has already started going into that service, and we have an action plan that has been agreed by the MDT, including also CQC in there. The practice has joined up with HICHAM, which is within the West Norfolk, in terms of working together, sharing the work that they're doing, as HICHAM is also in that CQC action plan. So good progress is being made. There are no immediate patient safety issues. The issues that were identified that were immediate have been corrected in that. In terms of the themes around this, it's around leadership, it's around medicines, it's around governance. So the same issues that we've seen in the recent CQC. And you'd see that as I move on to Wensum Valley, that is the similar. So again, we've got a good rating for caring and the ability to respond. Then again, the same issues around the well-led domain as well as the effectiveness, giving them an overall rating again of inadequate. So there are common themes in this. And also I can confirm that an action plan is in place, and we've got the resources, both external resources that have gone into the service, as well as the CCG resources that are supporting the practice, as well as CQC colleagues are attending weekly meetings with both practice separately, and we have got monthly stocktake kind of meetings with localities, the practice, and everyone else. So a lot of work has gone into supporting the recovery process for these practices. In addition, I suppose the challenge again last month from the committee members were, how are we anticipating other challenges and how are we preparing ourselves for other practice that may be in similar position that have not been inspected over a while. So we did take some suggestions. We've kicked off a program of work which is about learning, and around leadership. CQC has kindly agreed to support or work with the CCG to work on leadership issues, cultural change issues. So that's a really strong element to drive those system improvement. And obviously we've had some conversation with our medicines department, Michael is here, about putting some sessions as well to drive the learning and the improvements that are needed in that area. And again, governance is one of the key areas that as a system we need to improve with our practices. So we'll put some sessions in that to drive those improvements. So those are the 2 CQC reports. unless there are any questions.
Thank you, Shepherd, for the summary. Tracy.
Yeah, thank you, Shepherd. It's really helpful. And although from what you were saying about both the practices, there are similarities, certainly the resilience, the leadership and other things. One thing that occurred to me, the practices, probably their patient demographics are quite different. I know that Western Valley is particularly in a deprived area, which we would call, I think in a primary care sense, a deep end practice. And I don't know that Manor Farm is. So there's something again about the patient population and what services support a patient population in the area, as well as those things that you outlined being the culture, the leadership and those systems and processes as well. I don't know if that makes sense, you know, kind of thinking about where that demographics of that population are and how that affects that practice really, and how patients access that care and the resilience of staff within that practice as well, potentially.
Absolutely. I think there are some differences, some variations, and I hope we could pick through the leadership lens in terms of understanding those issues and support the teams to be able to drive the relative improvements for individual parts. Yeah.
John.
Yeah, two questions if I may. And I think Shepherd's covered this, but just conscious that both of the reports said that the practices were inadequate for safety. So just getting that assurance that we've had assurance, if you like, that services are safe for patients. I'm pretty sure you said that, but just wanted to double check. The other thing was it's useful to see these reports in individual practices, but I quite like to see them in the context of the whole as well, which is an understanding of the 105 practices and how many have we got that are inadequate and how many are in the different categories, because I think, you know, we're rightly focusing on these practices, but the overall picture, I think we need to be rooted in that. And also you mentioned about the themes, Shepherd. I think it'd be useful as these reports come through to keep a view on the themes that are coming up and understand a bit more about the actions that we're taking, where we're able to take actions to support practices with those themes going forward. And I'm sure we're doing all that in the background, but I think for assurance to this group, it would be useful to understand those themes and, as I say, the actions that we're taking. Thank you.
Absolutely. Thank you for that. And I think the systems approach will probably have to think about how do we bring that and provide assurance in that. Again, the themes, it's something that I will probably take us to continue to bring here. In terms of patient safety, I can confirm that there are no safety patient issues that are immediate that I need to surface here. All the cases that were identified by CQC, they have been assessed and it has been corrected on those, and it's actually in the report there that you have.
Just picking up on John's point about the themes. Well, I know we do sort of regular sort of communication to practice, you know, practice GP newsletters type thing. Is there sort of a slot within those newsletters to highlight, you know, themes that are emerging so that, you know, people are pre-warned and actually be proactive about reviewing their own surgeries, so that, you know, it's no point leaving things until they're found out. We need to be proactive and actually deal with it so that it's better for patients and it's better for the practice.
Sorry, I've got some background noise with garbage collection happening at this end. Sorry.
That sums up my comments, doesn't it?
I suppose, Doris, we'll probably just need to think about which platform is suitable to share the good practice. I think the lessons learned program that we are doing will be one of them. In terms of the GP newsletter, I'm happy to be guided. I think I'll discuss with Sadie to see how, if it's appropriate, we can utilize that space.
Yeah, that's fine. It's just about sharing learning and being proactive about it, so that people are not caught by surprise, because we do see this recurring theme of the last sort of few reports. You know, medicine is quite often is one of the issues, and actually being proactive with practice to highlight changes that is needed, I think will be helpful. Peter.
Thanks. Just two quick points. One, to pick up on that theme of the themes. I'm sure it was implicit in the message, but a theme could always be geography. And I think that might be another benefit of that overall view, is just to think about the map of Norfolk and Waveney, and do we have any theme when it comes to geography? And the other point is to raise that there is a slight difference between the two inspections, which is that in relation to Manor Park, a warning notice was issued, which indicates that the inspectors thought they were actively in breach of a regulation. And I draw it out for two reasons, and it isn't to bash the practice or to make a point. I draw it out, one, just because I think that governance, and we've had some of this in the services that we commission away from primary care, governance is often the thing that wobbles when we're under pressure and when staff are diverted into firefighting the incidences of the day. And again, I think that if we're well led is not a great title for that sub-element of inspection, which is where both the practices have fell down, because under that is all aspects of governance. And as I say, I think it's not surprising that can be the thing that wobbles. The other reason I raise it, and it's undoubtedly on the radar, the practice might not want to have that warning notice sat there until the next inspection happens in what might be many months or years to come. And certainly we've not intervened, but we've had communications with the CQC to ask them to revisit in order to inspect whether or not the breach is now no longer in breach, where the regulation is now complied with, so that the warning notice can be lifted in one or more of our services. And so I'm sure that's on someone's radar, but that might be worth just a pin in the calendar to look to do that, so that warning notice isn't hanging over them for an extended period. Thanks very much.
Thanks, Peter. So did you want to come in?
Yeah, I was just going to add a couple of bits, if I may. All really, really helpful and constructive comments, so thank you. Shepherd mentioned earlier that the CQC is actually part of the team that reviews the action plans and what have you. So I know that what we've seen where there has been a notice applied is that the CQC have prioritised coming back to the practice, and whereas they might leave it a bit longer if there is no notice period, but certainly they are being very, very frequently appraised of progress against the action plan. The other point I think, Doris, that you raised was around, being proactive in our support of practices, and I think we have done a lot of work on that. We've got videos that colleagues in the quality team have helped, videos of training. The medicines team have been doing a lot of work around making sure that there are the searches shared and practices are aware of what's being looked at, and of course that might well go down the priority list of an individual practice until they know that an inspection is near. And I think what we are really seeing is because many of our practices haven't been inspected for many years, the two inspection regimes are very, very different. So Manor Farm, for example, was not inspected since about 2015, 2016, I think. And so what it has done is, in that particular locality, really enthused the neighbouring practices to have a good old focus on this and work together, which is not great for Manor Farm, but it's they're being very proactive in the rest of West Norfolk, and we continue to push this across the rest of the patch. But yeah, it is something that we are trying to do to support practices to be ready for their inspection, because they only generally get a couple of weeks notice of an inspection, and by that time it doesn't give you enough time to do all of the preparatory work, checking that everything is in place.
Yeah, and I don't think only doing work when you're about to be inspected.
Exactly.
Right approach.
Yeah, exactly.
you know, there shouldn't be a good practice. I mean, we will have bad days, but a good practice, if an inspector walks through the door tomorrow or now, would still be a good practice, and actually is having that expectation and quality and patient focus and delivery of a good service. That is at the heart of what we need to be really encouraging. Thank you for that. Are there any other questions or comments from anybody on the reports? Great, thank you. I will move on to item 9, which is locally commissioned service. Is Gina joining us for this? Oh, magic, she just appeared.
I've been loitering in the background. Hello, welcome. It's a very high level whiz through for you today, because things are happening rather than rather than the problem solving stage, I suppose. Things have all started to happen at pace. So very brief touch base. Phlebotomy, you'll be now glad to hear, is live with general practice across the entire patch. We no longer have third-party services delivering, which is very good news, and I'm very grateful for the practices involved transitioning that so smoothly. Spirometry, the toolkit has now gone out, and there's guidance gone out to everybody that they should have restarted spirometry. We're almost at the stage of the first period reporting at the end of the month, so we've got 2 more weeks, and then we'll actually be able to understand the numbers that have actually taken place. Although with the spirometry, we expect it to be lower than anticipated due to the delay of reissuing the guidance. And then finally, the proactive healthcare, which is a reallocation of the PMS monies. We have an internal meeting next Wednesday afternoon to sign off the submissions through from practices. And that's actually been really eye-opening. Practices have got really engaged in how they can actually work across a system level to be able to better support patients, how they can engage with our acutes, how they can engage with the voluntary sector, and how they can use data to support the projects they're submitted through. So that's been really positive, considering the pressures they're under, that they are focusing very much on their patients. Some of the practices are working as individual practices, some are working as PCNs, and we've actually got one working as an entire locality together. So I'm really positive we'll have some positive outcomes. I'm happy to summarise those for the next paper in July, if we still wish to have one from me, once we've had those signed off, because they're kind of in that final stage at the moment. With regards to the searches and reports, we've done a lot of work for general practice this time, and also more to the point of consistency for commissioning is by identifying we've actually created the searches which they undertake and to do all the work that they're looking at. This has got 2 aspects for us. One is because we've created the templates, it means that the patient should get a better, more consistent treatment, no matter which practice they go to. But more importantly, we really get a strong understanding of where the activity is taking place, because we're now using a much smaller suite of read codes as opposed to the previous thousands that were available. So again, Q1, I expect to be slightly different, because the searches and reports only literally trained on them last week to the rest of the practices. So we've allowed them to go through and modify them slightly for Q1, but by Q2 they should all be used consistently. And again, CQS Local opens up next week, which is another new step for the CCG. I think as a CCG, we're the one who's taken on the greatest undertaking of CQS Local, and as much we put all our LCSs on it. And I think the aspiration from the finance team and the engagement team is that any engagement payments we have with our practices all goes through the same platform. The benefit being substantial as far as the finance team, as far as invoicing and raising goes, but also as far as practices go, again, it's consistency and minimising bureaucracy, which we want them to concentrate on patient care. We don't want them managing back office elements. And then obviously we're working internal tracking. The key elements that we have omitted to deliver for this meeting is the patient survey report I had promised you. The key reason for this is the fact that when we started reviewing the 52 pages of comments that came from patients, some of which are very informative, some less so, it really highlighted that patients have very little understanding of what GP practices are actually meant to do, as opposed to what they think they should do. So what we've decided is that we're going to put the meeting together, say to Paul and myself, is a bit more detailed in order to try and look at not just what the LCS changes have been, but actually how we can build on the core practice services, because some of the stuff that's arisen is that practices are potentially being judged on something they're not supposed to deliver in the first place, and therefore it's kind of building up resentment from patients back to those practices when they're not understanding. So the correlation, for example, came quite strongly between doctors and dentists, and doctors being berated for lack of dentists. Now clearly that's not linked at all for our primary care practices. So when we look at the engagement report back, we're going to try and look at that slightly wider. So that's one of the reasons that's been delayed. The warfarin mobilisation, as we're aware, is substantial in the east of the area. We're moving from venous sampling to finger prick testing. We had anticipated to go live literally the middle of this month, kind of next week, with the first cohort. We've delayed it for a month in order to allow a fuller transfer of data from the acute into primary care for these patients, and a greater background understanding of their historic reasons and management regimes within warfarin. The reason we've done this is that the information we've been able to extract from another system is more limited than we had hoped, and therefore we thought that it's actually better for safety and for patients to actually delay the rollout by a month to allow a proper review and uploading of patient data and transfers and checks and balances than it is to rush it through and hope, which when we're looking at 3,000 patients and we're looking at warfarin, is not something we wish to do. So that is now tied in, all practices engaged. We have 3 left out of 25 in total who've yet to just do their final training, but again that's well underway. So again, really grateful to practices for the undertaking for that. And then just finally, we're ongoing talking to practices. We had 98 engaged last week in the 2 training sessions I ran with practices, which is fabulous engagement with them. And we'll be running fortnightly sessions right through to the end of July through that first reporting process, so that they understand what they need to do and they'll have that full and direct understanding of any queries they've got. That's it, as usual, quick fly through. Any questions or queries?
Thanks, Gina. That's very helpful, and it's really good to see the progress that's taking place. I know it's been a long, hard slog to get to where you are or where we are now. So very grateful for your work and your team's work. Are there any questions for Gina on the report? You stunned us into submission.
Can I just say a thank you to the committee? This has been a really challenging project right through from September, October. I picked it up last year, but the challenges that I've received from yourselves and the support and the pragmatism we've had for driving this through, I think it's actually delivered it into the successful rollout it's been. So thank you very much for that.
Thanks, Gina, and no doubt there'll be a report to going forward as progress as things become embedded. So thank you. On to prescribing.
Okay, thanks, Doris. Take the paper as read, but I'll just highlight some usual comments within the paper. So we've had our March data has come in, and our performance, we had an outturn of 172 million, which was a 2.3 million underspend against the budget, so minus 1.3% after taking account of recharges and rebates. So possibly a different figure to that reported elsewhere. Dependence forming medicines, so the 3 items have all improved. High dose opiates has gone down some more steps in terms of National League. Gabapentinoids has gone down. Hypnotics and anxiolytic, the volume has gone down, but again, we're still remaining at 3rd nationally. Sadie alluded to some work we've just started with the mental health NSFT, some joint work around our initial response to the National Overprescribing Review, which came out last October. Nothing much has happened with that as yet, but mental health is our key area of potential high volume prescribing, and therefore viewed through the lens of overprescribing. And we had a very successful high level discussion about some initial plans with the NSFT, who are very much recognise our outlier status in a lot of mental health drugs and are up for culture change and we've got some initial plans to do some talks to GPs with some of the mental health teams and the PCN mental health pharmacists to do some work on the ground around culture change within the medicalisation of everyday life, for instance. So how we treat anxiety and insomnia without resorting to drugs initially, because that's part of how we've got to where we are in terms of those indicators. So going forward, I will put in a section about that work as we develop our plans and start to implement them, and some of it will actually have some financial benefit as well as improving quality of life once we can come up with non-drug treatments for patients, and different approaches, and change our culture. Antibiotics, slightly over target. The current target on both indicators, in terms of volume of antibiotics, we are below the last year's indicator, and part of my team and our GP prescribing advisor will be approaching PCN clinical directors and their teams to offer support to practices and gain their support to talk to practices around outlier status in terms of dependence-forming medicines, particularly hypnotics, gabapentinoids, but also antibiotics. There's a couple of PCNs which are significantly skewing our data, as you can see on section 4.2. And there's our outliers, which we've decided our route through to them is through the PCN clinical directors. We had initially approached some of our outliers in some of the dependence-forming medicines, and to offer proactive support in developing plans, etc., and to help them change prescribing, particularly ones who are outliers and going in the wrong direction. But something was lost in translation, and it wasn't deemed particularly helpful. So we are changing our approach and going through PCN clinical directors, and we've got a GP and a senior pharmacist who'll be leading those bits of work. Comments welcomed.
Thank you, Michael. Tracy?
Yeah, just going back to the antibiotic prescribing, and certainly the kind of the trend in respect of antimicrobials generally has gone up, and I know that there's been a change in the way that's been kind of calculated from what you've said. But
yes,
just thinking about I being an independent nurse prescriber, and I don't have this data anymore, but there was a time when I would have my prescribing data, so you would have it at the person. Oh, sorry, doggy. At a per person prescriber level. Is that still available? Because that's actually quite powerful when you have that. I apologise, someone's at the door.
Okay. Those data, particularly for nurse prescribers, does come with significant health warnings, and particularly if you're a training practice, because the trainee doctors their prescribing will all go underneath their supervisor, and it's normalised for list size. If you're part-time, if you're seeing urgent patients, so it comes with lots of health warnings. We can provide the data, but it's important we're not judging necessarily on that data, and you have some internal conversations with it. So if you want it, but be careful what you wish for, because nurses aren't normalised. You will stick out on the graph.
I don't mean generally, yes. Sorry, I think it got lost. I think generally for a prescriber, so your own data is often quite powerful. If you are kind of highlighted if you're prescribing an increased amount, and certainly that needs to be managed in a reflective and a supportive way. But your own data is very powerful, isn't it?
For personal reflection, yes. Oh, yeah. So, very happy to. We don't have the resources to do that routinely, but for anybody who asks, we can put together a small pack of data, or down to individual prescriber level. That does mean we have to go onto the national system and pull the data off. Unfortunately, there's not a portal where you can go and get it yourself easily. But we're happy to do that for those that want it, rather than spam those who don't really necessarily want to see it.
Okay, I wonder if if a PCNs you're targeting, maybe that's an approach that they wish to take potentially.
Yeah, good thought. I shall write that down and talk to my two colleagues who are going to lead on that bit of work. Yeah, okay. But with the caveat that the data is what it is, and it comes with health warnings. So individuals can't use it to bash other individuals, because it can be very skewed very easily.
Thank you. Are there any other questions for Michael? No. Thank you for the report, Michael, and no doubt we will hear from you again. There isn't a finance report for this month because it would be reporting on month one, so it's not an oversight and we've forgotten. It's just normal practice that month one finances are not reported. Have there been any questions from the public since we've been meeting, Sarah?
No.
No, thank you very much. Before I ask any business, I must apologise. I should have welcomed Stephen to the meeting. I noticed that you joined us. Stephen's the new CFO for the ICS, whichever initials fits. Welcome. I hope it has been helpful as you step into the role come July. So that's my being a bad chair, not recognising it right at the beginning, and also being a bad chair for running overtime. Actually, this is probably very unusual for me to run overtime. And this is my last meeting as chair of the Primary Care Commissioning Committee. And as we transition, I want to thank my colleagues for your support and your insight, and just generally putting up with my not very good sense of humour sometimes. And I wish you all well, and no doubt I will see some of you in person at some point somewhere in Norfolk. And for those who are continuing with the Primary Care Commissioning Committee going forward, good luck. It's a great committee, and thank you to the team, and actually real big thank you for Sarah, who is always behind the scene, keeping me in place and typing up our ramblings into sensible minutes. So thank you all. And for those who have the misfortune of having to join us for part two, if we have a sort of 10-minute break, come back at 3 o'clock, if that's okay. So thank you.